So hello everyone, can you now see me? Am I audible to you? Please show me a thumbs up or write down in the chat box if you can see me. So sorry for the technical trouble. There was some problem in the settings and actually I could not do this in time. So good afternoon everyone. Now I think it is good time to start with the very important topic today, which we are going to discuss at YouTube session at Unacademy, guys. So welcome everyone to this session at Unacademy. We will be discussing today top 10 most expected images which can be there in your upcoming INI CT exam. Okay friends, so just a brief about myself. I am Dr. Shivani Jain, your NEET PG educator, MS Ophthalmology, and I authored a book, Ophthalmology Notes, which is very famous among the foreign medical graduates. Now we can be connected, guys, at various platforms. So we have a Facebook group and there is a Telegram group also with the same name. So on all your plus subscriptions at Unacademy, you can use my code SHIVIJ, friends. Okay. Now just to brief you about Unacademy, guys, this is a wonderful platform which you can download easily at Play Store, and you can select whatever category you are in, NEET PG or FMG. And once you have that plus subscription, you can have wonderful things like the daily live classes. We have all the structured course at Unacademy where you can have live tests, quizzes, and the best part about Unacademy is that you have unlimited access. You can see all the videos, unlimited time with your favorite educators. Okay. Now the best part about Unacademy is that nowadays they are giving you the best of prep ladder also with the Unacademy at its best. So you can have the newest QBank 2.0 from the prep ladder, all the recorded videos, everything with most of your topmost countries educators with a rapid revision course as well. So everything is available at Unacademy, guys. बस आप पढ़ने वाले बनिए और सब कुछ मिल जाएगा आपको. So without wasting much time, friends, let us just talk about the new courses which are there at Unacademy. You can join every day at 9 p.m. every day at 8 p.m. We have different batches for 2021 and 2022 for NEET PG. Now let's begin with the first question, the first picture, interesting picture here. Can anybody tell me what is this chart? This is our first topic, the first chart. Can anybody tell me what is this chart? So namaste everyone. Good afternoon. So this chart is a very famous chart, but this is not a Snellen's chart. This is called as Bailey's and Love chart. Okay. So this is not your surgery book, Bailey and Love, Love and Bailey. This is your Bailey and Love chart for checking the visual acuity. Okay. So this is not your Snellen's chart. Now another name of Bailey and Love chart is ETDRS chart. You can also call this chart to be a logMAR chart. Okay friends. So all of you, Dr. Muhammad, Dr. Jagdish, Kushal, Muhammad, Lucky, this is not Snellen's chart, friends. Please understand. My picture is much bigger in size. That is why probably you are not having a full view of this chart. This is your Bailey and Love chart. So guys, first of all, try to identify why it is not Snellen's chart. This chart is different because it has same number of letters in each row. If you can see, the topmost line has 5 letters. The subsequent lines, all the lines are having actually 5 letters. Now this chart is constructed in a different form because the space in between these two is same as that of the width of the letter. Similarly, the difference in between these two lines is same as the height of this letter. So this is a very different chart. Every alphabet has its own individual score, has its own importance. Okay. Now Snellen's chart, you just have to read one line. If you can't read one of the letters, it doesn't make any difference. It doesn't make any sense. But here, each and every letter, this letter has an individual score, this letter has an individual score. Now this logMAR chart is called as logMAR because here we are calculating the visual acuity based upon the minimal angle of resolution. Okay, so here the 6 by 6 line which we take on Snellen's visual acuity test has been given a notion of 1, which means a log of 0, isn't it? So there is a minimal angle of resolution of 1 at 6 by 6 line, which means the log value of 0. Okay, so at least this much you should remember, that this is your Bailey and Love chart. It has 5 letters in each row, and then the 6 by 6 letter is on the Snellen's chart is corresponding to a minimal angle of resolution of 1, which means a log of 0. Is that clear? So just give me a few seconds because I want to change the picture size, guys. Please be patient. So I want to change the picture size so that you can have a better idea of all the pictures here. Just give me 1 second. Okay friends, so in Western countries, let me continue with it. In Western countries, more often we use this logmar chart. In Indian scenario, we use more of Snellen's chart. We have the visual acuity like 6 by 60, 6 by 36, 24. They have in this logmar units. Okay, so they evaluate this in the logmar units. This distance remains the same. Okay, so it also has to be read from the 6 meter distance. So Dr. Keshav, is that okay? So we have to check the visual acuity from the same distance, but you have to remember that there are 5 alphabets in each line. Each and individual letter has its own significance. We give each and every letter a score of 0.02. So each and every letter has been given a score of 0.02 on logmar scale. Okay, so much of detail is not necessary. You should be able to identify the chart first of all, and the information which I have given you, that it is based on calculation of logmar. And what is the difference? Each and every letter has a different individual score. Okay friends, so that is all I can tell you, because for last 2 years you have been asked questions on Snellen's chart. So this year I believe they can make a change. They can ask you something different. Okay, so we'll keep on discussing the next pictures in our further lectures. Now guys, question number 2, can you identify this corneal pathology? Can you identify? So this is a corneal dystrophy. So can you tell me whether it is a lattice dystrophy, it is your macular dystrophy, or a granular one? Which is this? Can anyone tell me which is this dystrophy? So I'll help you out, guys. This is your granular dystrophy. Okay, so how to identify? So granular dystrophy is basically a corneal stromal dystrophy where there is an accumulation of hyaline material in the stroma. Okay, Jagdish, Dr. Jagdish, this is not lattice dystrophy. In lattice dystrophy, amyloid material is deposited and the pattern there is crisscross lines. You know, if you see crisscross lines crossing each other in the cornea, you will say it is your lattice dystrophy, but this one is a granular dystrophy. Now I'll tell you more clues how to identify. Very good, Dr. Soham, Dr. Nargis, very good. So how to identify? Clue number 1. First, very important clue is that you see popcorn-like lesions, isn't it? Can you see? We call them popcorn-like lesions. Okay, this is the first clue. Apart from that, you will find out that this is not going till limbus. So limbus is always paired. Can you see? Limbus is not involved. The third very important clue is that you have clear areas in between. Can you see? This does not have a diffuse stromal hedge. Okay, so there are 3 differences. Let me tell you again. First of all, you will see popcorn-like lesions. Limbus is not involved. This is mostly limited to your central cornea. The third thing is the intervening corneal stroma is clear. Okay, that is how you differentiate. A very, very important thing, something about the stromal dystrophies. You need to know these 3 stromal dystrophies, very, very important. Now, can anybody tell me how do you diagnose this? Apart from the clinical diagnosis, how can you stain? How can you diagnose this? What is the stain here which we are using? For granular, what can we use? Mason trichome. Okay, so this can be diagnosed by Mason trichome. All right. Dr. Salvan, I would not say this is for FMG. Only 2 to 3 pictures can be there in your FMG exam. It is mainly for your NEET PG entrance. Okay. So now, next one. What is the use of this investigation? So can anyone tell me what is the use of this investigation? Which investigation is this? So basically, this is something which is called as corneal topography. Okay, this is your corneal topography picture. Now all of you can see that there are some color coded maps, isn't it? You see beautiful colors here. Some color coded maps are there. So if you have such a picture, first of all think about the corneal topography. Now it is based on a Schlein-Fluke principle where there is a rotating camera and it captures various levels of scan on the cornea. So it takes every notation, everything about cornea. So it tells you every curvature, each and every place, what is the thickness, what type of astigmatism is this, where is the cornea thin, what type of astigmatism, and so many things. So it gives you every information about the cornea. Okay, now how to identify whether it is a normal scan or abnormal scan, that may be your question. So you know green signal. Green means everything is okay, go ahead, green signal. So whenever you see more of green areas, especially in the center, think about a normal scan. So can you see green, green, green? This is a normal scan. Okay. Now when you see more of hot colors like red, okay, red appears very beautiful, red, but this hot red is actually abnormal. So how can you remember? The hot colors like red and orange, they suggest that there is some abnormality, and this abnormality is nothing but thinning. You can say there is a thinning, or there is a steeper curvature, okay. So just this much is required for you. You need to see whether this is a corneal topography normal scan or a abnormal scan. Okay, very easy to identify. Now if you want to go more in detail, you can also see about the thicknesses. So this third number map will give you various levels of thicknesses at various places. Okay, so you know that normal corneal thickness is more than 520, isn't it? So if you have more values, approximately 520, that means it is a normal thickness, normal scan. If you have less values, that means it is a thinned out cornea, it's an abnormal scan. Yes? Is that clear? All of you? Shall I go ahead with the next picture, friends? Okay, so the next one is a very important field change. This is a picture of a homonymous hemianopia. Now guys, this is a normal field. This is a normal visual field where your right eye has a blind spot in the temporal side. Blind spot is always on the temporal side, right? Now this is your left eye where the blind spot is again on the temporal side. Okay, blind spot in the field is always on the temporal side. So what do you see as a defect here? We see in the second picture that there is a loss of field on the temporal half of the right side and the nasal half on the left side. So this becomes a homonymous hemianopia on the right. Correct? Loss of half of the field, corresponding half of the field on the right side. This you have to imagine, this you have to see from the picture. Do not get confused, friends. This is not a left homonymous hemianopia. Okay? Easy to answer when you have such a concept that blind spot will always be there on the temporal side of the field. Okay? Clear? Okay. Now, very simple question but important one. Expected question because you never had a picture of macular hole in your exams. So what is the diagnosis based on this OCT picture? So I'm sure all of you can recognize that this is the optical coherence tomography picture, and this is an abnormal picture. Why? Because the normal foveal contour, this should be the normal foveal contour, this is absent. The normal foveal depression is not seen. What actually you can see is a full thickness defect in the layers of the retina. So this is what? This is a full thickness defect in the all layers of retina at your fovea. So this is definitely a full thickness macular hole. So very good, Dr. Avinash, Dr. Anurag, everyone, very good. This is a full thickness macular hole, okay? Now, so my question here is, what is the most common etiology? And on which stage do you find this? So it is stage number 2 when you start developing a full thickness macular hole. In stage number 2 only you can have a full thickness. What about most common etiology? So it is idiopathic. Okay, you must know these questions. These are very, very important questions on macular hole. Okay. Now, so everyone know that this is a picture of Amsler grid. So this is a picture of Amsler grid. Can anybody tell me? No, Dr. Avinash, trauma is not the most common cause. Traumatic macular holes are very less as compared to idiopathic. Okay, it is idiopathic hole which are most common. Anji, so can anybody answer me? What about Amsler grid? How much field is tested? Jagdish, very diplomatic answer. Very diplomatic. है ना? It is a diplomatic answer. So if I ask you, Dr. Jagdish, 10 degrees, 20 degrees, 30 degrees, 40 degrees, what should be the answer then? Dr. Jagdish? So yes, Dr. Avinash is absolutely right. You have to say central 20. Guys, this is a confusing question, है ना? Earlier even I used to get confused. Let us see how to understand. Now, so Amsler grid is basically a chart which has almost 400 squares. Okay, there are 400 squares, 5 millimeters each. Okay, very good. Now, this is the central fixation point. Now, when I ask the patient to close one eye and look at the central fixation point and see if the lines are in normal pattern, so it can detect basically the central pathologies basically. If you have macular pathologies, you will see wavy lines around the central area. Now, if you have optic nerve pathologies, so there may be some scotomas as well. Okay, if you have optic nerve pathologies, you may have scotomas as well. So it does not only test your macular pathologies, it gives an insight about the optic nerve problems also. Very important question. Now, how to remember? So if they ask you how much central field, you have to say 20 degrees. So this is 10 from the center. Okay, this is 10 from the center. So how much it becomes? 20 degrees. Okay, so now never say it is 10 degrees. It is 10 degrees from the center. But in total, it is testing your 20 degrees. Have you understood this concept, friends? So now don't never say it is 10 degrees or 30 degrees. It is 10 on either side from the central fixation point. Okay? So let's see the next one. So guys, this is again an expected question. This is a type of ptosis which has a autosomal dominant inheritance. So I have given you a clue. This is a typical picture of blepharophimosis syndrome. Blepharophimosis syndrome, okay? So what is the meaning of blepharophimosis? This is a very, very characteristic picture. Blepharo means lid. Phimosis means a small. So can you see the palpebral aperture? Palpebral aperture has become very small. Can you see? Not only horizontally but also vertically. So there is a phimosis of the palpebral aperture. So blepharophimosis. Now what about this E? So E is epicanthus. Okay, this is a very, very important, right, guys? Blepharophimosis, epicanthus. Can you see there is an epicanthic fold? This epicanthic fold is called as epicanthus inversus. Again, an important question. They can ask you in blepharophimosis which type of epicanthus is present. So it is epicanthus inversus. Very good. Now, what can be the other features? You have a severe ptosis. You have a severe congenital ptosis, and you may have a telecanthus. You may have a telecanthus. You may have a lateral ecteropion. Very, very good. All of you, very good. So, these two are not always present. Telecanthus, lateral ecteropion may or may not be there, right? Now, these are some features. So, can you also see that you have a thick eyebrows and frontalis overaction? Okay, can you see? So, there are some more features which you need not to know, but at least this much you should be able to identify. Which type of epicanthus is this? What is the typical tride? And what is the meaning of phimosis? Okay, so it can run in families, guys. You can see this in most of the people in the family. So, let's see this test. So, it's a very important question. Theoretically, you have this question earlier in your exam. So, can anybody tell me which is this test? So, this test is a very famous test for ophthalmologists. Breakup time. BUT, breakup time. Okay, breakup time. So, what is this breakup actually? Breakup is not with your friends or girlfriends. Breakup here is the breakup of the tear film. Can you see a dry spot here? A small isolated dry spot here. Okay, so this is a test which I would say one of the best tests to diagnose the dry eye. No, bache, this is not Seidel test. Dr. Chakravarti, this is not Seidel test. Okay, here also we are using fluorescein dye. Here also we are using fluorescein dye, but actually what I am seeing, let me explain you. Yeah, let me explain you. So I want to check whether the dry eye is because of insufficient or abnormal tear film or not. Okay, so I am checking whether my dry eye is because of an inadequate tear film. So what will I do? I'll quickly stain the tear film with the help of fluorescein dye. And afterwards, I'll ask my patient to blink frequently, 2 to 3 times, so that the regular tear film is spread. Now, I'll ask my assistant to note the time. So, I'll ask the patient to now open the eye, and from the slit lamp, I will observe the presence of first isolated dry spot. The moment I see that dry spot, that means the tear film is broken. And I'll instruct my assistant to stop. So that particular time from the closure of the lid to the appearance of the dry spot, is my breakup time. Okay, have you understood, friends? Clear? So this is a very, very good test, and it is said that if the tear film breakup time is less than 10 millimeters, it becomes significant. It is a significant period, okay? That means it is a poor breakup time. Your patient has definitely a dry eye. We all have a breakup time for more than 15 seconds, I would say, not millimeters, it is seconds. So more than 15 seconds, I would say normal, but less than 10 seconds is a significant for dry eye. Clear, friends? Hope you have understood. So this is not our Seidel's test here. This is a test for dry eye. Now, something with the squint. Can you identify what is the pattern of squint here? I really want to discuss such type of questions more with you guys. So can you see what is the pattern of squint? Take few minutes, few seconds you can take. So how to approach such questions? How to approach? So what I do is, first of all, see the primary gaze. Can you see there is a little exotropia here? Exo. The eyes are divergent. So there is a kind of divergent squint, exotropia. Now what is happening when the patient is looking up? When the patient is looking up, the exotropia is increasing. Can you see? It is increasing. And when he looks down, the exotropia is almost becoming normal. You hardly appreciate there is an exotropia. Okay, so friends, this is not third nerve palsy, not at all. This patient has a V pattern squint, V pattern exotropia. Okay, so partly Dr. Jagdish, yes, Dr. Jagdish is absolutely correct. So this is basically a V pattern exotropia. Now why it is not a third nerve palsy? Let us see why it is not. Why it is not? Because this movement is okay. This movement is also okay. Both dextroversion and levoversion are okay. So how can it be third nerve palsy? Am I clear? The eye is not down and out. What is classical with the third nerve palsies, guys? What is classical with third nerve palsy? A down and out eye. Yes or no? So in the primary gaze only you can exclude third nerve palsy. The eye is not down. It is only out. But yes, definitely we have to see all the gazes. We can't just see only one primary gaze and diagnose. It will be, absolutely a wrong approach. Okay. So I hope you have understood how to approach such question, my dear friends. Okay. Hanji, dilated pupil. Very good, Dr. Sonam. Very good. Good. Chalo, the last question which we have today is, what is the name of refractive error? Quickly, what do you think is the refractive error? If you have no option, so first of all, what I say is that this is definitely a astigmatism. Why? Because I can see two meridians. I can see two meridians. This is definitely not a simple thing. So what is it? Dr. Sai, it is not INO, beta. It is not INO. So which type of refractive error is this? So I would say this is a compound myopic astigmatism. Compound what? Compound hypermetropic astigmatism. Compound hypermetropic. Very good, Dr. Amardeep. This is definitely a compound. But why hypermetropic? I hope you can see that rays of light, both the meridians are focusing behind the eyeball. So this becomes a compound hypermetropic astigmatism. Friends, such type of questions can be there in your exam. They can ask you simple myopics, compound hypermetropic, anything. So you should know the basic concept. Okay, it has to be compound because both the meridians are focusing behind. Hypermetropic, again the same reason, eyeball is small, the rays of light are focusing behind. Okay. So this is all we have today, guys. I hope you learned something useful today. Okay, so you can write down to me if there's any topic which you want me in the upcoming days to be discussed. Tomorrow at the same time, guys, we have an important session, triads in ophthalmology. I would be discussing. Okay, triads in ophthalmology. At the same time tomorrow we will meet again, friends, 4 p.m. and if you have any suggestion for the further classes, I would be taking many YouTube sessions. If you have any suggestion, please let me know. In the next month, I'll definitely make some small videos which we can learn together. Okay. So that's all from my side. Upcoming live sessions ab hai. You please follow me at Unacademy, dear. Follow me at Unacademy. Okay. I am Dr. Shivani Jain. Just follow me at Unacademy. You will come to know about everything, and I am there to let you know. Okay. More questions हम बाद में discuss करेंगे. So I will be having one special session, friends, where I will be taking up 1.5 hours of all, important lovely questions, multiple mixed bag of questions which I will be taking on 31st. Okay, so be there. That would be 31st I will take in the afternoon. I'll let you know. I'll keep posting at Unacademy. Okay, so bye from my side, guys. Happy evening and enjoy your day.